Our first speaker is Associate Professor Margaret Simmons. Margaret Simmons is Deputy Director at Monash Rural Health, Churchill campus, teaching graduate medical students a social perspective on health. She has nearly 20 years experience in qualitative research and medical sociology, and she won both the Medicine Faculty Deans and Vice Chancellor's Awards for Diversity and Inclusion in 2020 of Melbourne. Margaret will set the scene for us on why inequity exists and how digital health can be used to help address inequity. So thank you, Margaret.
Thank you so much, Wendy, and thank you to T for driving my slides today. So hopefully you can all see those. So yes, my name is Marg Simmons. I would also like to thank the organisers for inviting me along to present. This session is about grounding the discussion. So as Wendy said, I'm a medical sociologist. I teach 100 graduate entry medical students in Gippsland. I'm zooming in today from Churchill, which is on the unceded lands of the Gunai-Kurnai First Nations people. And I'd like to pay my respects to elders past, present and emerging, and also acknowledge any Aboriginal or Torres Strait Islander peoples here today. So I teach the students a social perspective on health. We look at big picture issues that impact on patients, particularly around things like social justice and equity, inequities as well, such as topics such as family violence, the media and health, disability, refugee health, rural health, and much more. And how awesome is it that we can all be together virtually with no travel miles or travel time racked up? It's really good for sustainability. At the same time, I must confess that I still find technology somewhat daunting. And I grew up with analog time and the imperial system, so we had to learn the 12 times table for pounds, shilling and pence, feet and inches. We had to go to an encyclopedia for information, and we used cards and microfiche in the library to look up details, a time well before Google became a verb. Now I can do all of that on this little device. And, in a term, we call this convergence, where things converge into one tiny little computer in a way. I mean, I worked in an organisation where a computer used to take up the whole floor of a building, and now that computer is not even has as much memory as this one. Next slide, please, T. So I wanted to provide everyone with a way of framing digital health equity, a way of thinking about this through a sociological lens, giving you a tool that I think is tremendously useful for any social issue. I even call it a gift. I give this gift to the students. It helps them, and it can help you explore what we know are very complex social issues. I also need to declare that I'm not a digital health expert. I think we all can concede that there is much that we don't know, many unanswered questions, and as Wendy alluded to, many gaps in this emerging field. But instead, I want to pose some challenges for you today and hopefully stimulate discussion throughout the day and beyond. Next slide. So why is digital health equity so important? Well, if we start with inequity in society, we can see that those at risk of social exclusion, that is those who are at a disadvantage due to things often beyond their control, for example, unemployment, low education, a weak economic situation, the marginalised in society, they're also at greater risk of being excluded from digital health services. So no doubt you'll have heard of Sir Michael Marmot. He's done a tremendous amount of work for over 40 years around health equities and the social determinants of health. And this is Professor Michael Marmot's conceptual framework on health inequalities, inequities in his report, Fair Society, Healthy Lives. But when society is unfair or inequitable, we know that health suffers. And this is Marmot's plan for how to improve health and equity. And one challenge I would like to pose to you is to see where digital health could fit into this framework. For example, giving every child the best start in life, or ensuring that health standards of living are improved for all. And it certainly would come in at the last line. Digital health must be based on evidence. It must be researched and evaluated. But I think there are multiple points where digital health equity could be integrated in a model or framework like this to ensure that we provide a more equitable society. So, T, if you could now play the next slide, which has a little video in it.
So a final experiment that I want to mention to you is our fairness study. And so this became a very famous study, and there's now many more, because after we did this about 10 years ago, it became very well known. And we did that originally with capuchin monkeys, and I'm going to show you the first experiment that we did. It has now been done with dogs and with birds and with chimpanzees, but with Sarah Brosnan we started out with capuchin monkeys. So what we did is we put two capuchin monkeys side by side. Again, these animals, they live in a group, they know each other. We take them out of the group, put them in a test chamber. And there's a very simple task that they need to do. And if you give both of them cucumber for the task, the two monkeys side by side, they're perfectly willing to do this 25 times in a row. So cucumber, even though it's really only water in my opinion, but cucumber is perfectly fine for them. Now, if you give the partner grapes, the food preferences of my capuchin monkeys correspond exactly with the prices in the supermarket. And so if you give them grapes, that's a far better food, then you create inequity between them. So that's the experiment we did. Recently, we videotaped it with new monkeys who had never done the task, thinking that maybe they would have a stronger reaction, and that turned out to be right. The one on the left is the monkey who gets cucumber. The one on the right is the one who gets grapes. The one who gets cucumber, note that the first piece of cucumber is perfectly fine. The first piece she eats. Then she sees the other one getting grape, and you will see what happens. So she gives a rock to us, that's the task. And we give her a piece of cucumber, and she eats it. The other one needs to give a rock to us. And that's what she does. And she gets a grape. And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber. She tests the rock now against the wall. She needs to give it to us. And she gets cucumber again. So this is basically the Wall Street protest that you see here.
Thanks, T. So as you can see, what happens in societies when there are inequities and unfairness, that there are more social problems, more addiction, more crime, more worse health and lower life expectancy. So poor social determinants of health and inequity is bad for all. And certainly for these capuchin monkeys, they very quickly see that they're being treated unfairly for their work. And some might argue that there's also a double inequity here, because the monkeys are not only treated unfairly, but also put in cages and used for human endeavours with no free will or agency to do anything about their circumstances. And research tells us that it's similar for humans too. The less agency, the less control we have over our circumstances, the worse our health chances and our outcomes are. Now, when we think about equity and equality, sometimes they're conflated, but they do have different meanings. Indeed, some people think if you treat everyone the same, then you're being equitable. Well, not all people start at the same level. Some need extra assistance. So you can see in the image on the left, this shows what an equality setup might look like. All three people have the same box, but clearly not everyone is equal. They can't all see the game. There are differences in height, age, ability, and access, which mean that the playing field is not level and not a level one to start with. The image on the right, however, demonstrates equity. Now all three spectators can see over the wall as the three boxes have been redistributed in a more equitable way. Sometimes there might need to be more boxes given to the one person who has the most need, and that is a right and just thing to do. Indeed, some have argued that a more equitable thing to do would be to take down the fence altogether so that there is no fence between the spectators and the game. Next slide, please. So it is important to ensure that we are more equitable. We need less knowledge sometimes and more curiosity. We need more questions. Indeed, according to Albert Einstein, it is imagination that will help us come up with the answers. And sociology is key here, as it often involves asking good questions as much as coming up with those answers. Next slide. And one way of framing such social issues and looking at health inequities is through the use of the sociological imagination, which is the tool that I use for the students. So US sociologist C. Wright Mills in the 1950s and 1960s, a period of great upheaval and social change, first proposed the notion that individual problems become social issues using the example of unemployment. So he argued that if you have one person in a town out of work, that is their sort of peculiar or particular problem. But when you have 1,000 people in a town out of work, you have a social issue that needs investigating at the sociological level. And so to understand the individual, we must explore the history of a society in order to imagine different outcomes. Mills also argued for a particular type of intellectual craftspersonship through the sociological imagination, which ensures we see alternative perspectives and maintain a curious, indeed playful mindset. Next slide. Thank you. So following on from Mill's work, Australian sociologist Evan Willis developed the sociological imagination to include 4 elements of history, culture, structure, and critique. History refers to, how the past influences the present. Culture refers to how it impacts on our lives and how things are done here and how they're done in other places. Structure suggests how particular forms of social organisation shape our lives, and the critique is the most exciting element because it asks, can we improve what exists? Who benefits from this? How can we change the way, what can we do to make a difference? And we can look at digital health equity in terms of the sociological imagination, and that it would be my challenge to you today. Think about its history, think about the culture, how is it done in other countries? What are the structural implications, policies? And then the critique is how we can do it differently. Next slide. Another thing to remember when we think sociologically is to think critically and deeply, so not accepting things at face value. So what do we see in this image? 2 ants looking at a sunrise. But T, if you can move on. Well, maybe not. As Peter Burgess says, the first wisdom of sociology is this: things are not always what they seem. Indeed, Evan Willis describes socially as having a kind of a sensitivity, described as having your sociological spectacles or lens on, even what he describes as having a bullshit detector. So hopefully you'll be able to take some of that out with you too. Yes, thank you. So it is important too to check our privilege when we think, particularly when we're thinking about equity issues. As Indigenous physician and public health leader Marsha Anderson says, from now on, instead of vulnerable people, I'm going to use the phrase people we oppress through policy choices and discourses of racial inferiority. Next slide. And when I was putting this presentation together, I came across this digital equity framework from the City of Casey. So it's showing that there is lots of great work going on out there. I thought it was quite useful because it does pick up on many of the things I've been alluding to around equity, access, and diversity. The term intersectionality is important. It just means those intersections where people may experience multiple elements that can lead to disadvantage and inequity. And they may be things such as gender, age, sexuality, ability, ethnicity, and rurality. So they're things to keep in mind. Thanks, T. You're jumping ahead. You're being very intuitive. So the critique element, how can it be otherwise? And these are more challenges that I want you to think about. And I know that people are going to shudder when I say this because I'm kind of conflating digital health, artificial intelligence and technology. And that's another challenge, is defining the terms. I think that is very important, but please bear with me here. So one challenge with digital health and technology is it's sometimes considered impersonal and that people often find it frightening and alienating. As Eric Topol says, the relationship between doctors and their patients has been eroded in recent years due to a lack of time and depersonalisation of the clinical encounter. However, he also says that with artificial intelligence, patient-centred care can actually be enhanced. because the information required will already be analysed and interpreted so that the doctor can concentrate on the patient rather than their computer screen. In addition, improved health technology and algorithms will see increased accuracy, faster test results, which will be better for patient outcomes. And of course, we've all seen how useful, indeed imperative, telehealth has been during times of crisis, such as COVID. But in a nation prone to climate change with fires and floods, it may become essential. So speaking of challenges, more challenges and access issues, this is an image that I took while I was on holidays recently. It's our campsite at the Monday Music Festival outside Broken Hill. There was no internet, there was no phone reception, and frankly, that was bliss. Dancing to Midnight Oil in the outback, yes, but those access issues in remote areas of Australia are very real and are issues that must be surmounted. While the majority of Australians live around the perimeter and have little trouble with connectivity, we must remember that a third of Australians live rurally or remotely. And while digital health can be a lifesaver in some cases, particularly with the Royal Flying Doctor Service and telehealth measures, it can also be problematic. So that will be a challenge to overcome, ensuring equity for rural and remote Australians, and particularly remote Indigenous Australians who are at even higher disadvantage in terms of equity. We also have to recognise that certain groups have different health and digital health literacies. All of that needs to be factored in. Thank you. Another challenge is that AI and technology are not always the panacea that some of us might intuitively think. Tom Nash, a DJ, entrepreneur and motivational speaker, lost four limbs to meningococcal disease when he was 19. He says that he could have had electronic hands fitted, but prefers these more low-tech hooks, and says that they're more accurate and less complicated. So perhaps it's part of what I would call a Goldilocks principle, not too hot, not too cold, just right. So no tech, low tech, high tech, where high tech might not always be the best outcome. And this emphasises how vital it is to ensure that the client, the consumer, the end user is part of the conversation around digital health equity and part of the solution. In addition to including the consumer in digital health equity, Crawford and Sahal argue that along with person-centred care, digital health equity should be incorporated into health provider training and should be championed at the individual, institutional and social levels. As I mentioned before, evaluation and research will also be key, along with hardware needs, education and sustainability. And this all will factor into your planning and your R&D. And so my challenge to you is to keep thinking about the challenges of digital health equity, how they can be overcome to ensure that this space is inclusive and equitable for all. And that is the promise of sociology. As Mills argues, the promise of a sociological imagination to think about the questions and to think about the solutions. So hopefully today, in a very quick version, I've provided you some tools, some ideas to spark debate, some challenges that frame the ongoing conversations on this topic today and moving forward. I can see that there are some very exciting presentations and case studies that you will hear about throughout the day. And my next slide, I just want to give a little plug. Hopefully I've piqued your interest for the haiku workshop that I'll be running at lunchtime. It's you can bring your lunch to it. It's a very, mindfulness session as well. And then finally, I have some references to finish. I wanted to thank everyone for their attention. I'm really sorry I can't stay for questions, but I'd like to wish you all the best for the day, and perhaps if there are questions, they could be posted for the organisers and they can get back to me with some answers. So thank you all very much for your attention.